a few weeks ago. I had submitted a case a few weeks ago about a patient whose X-ray had a kind of incidental finding of atelectasis. And that got me thinking about atelectasis. And actually, I had called Allison on Friday after I talked to Mitra, Dr. Sela, asking her if she would kind of help out with this. So I see what we're going to do here as kind of a joint presentation and case. And actually, after I submitted that first case, I had about 3 more X-ray reports with atelectasis. And so I've got not the X-ray pictures, unfortunately, but the X-ray reports, which I know is a poor second best, but that's what we've got to work with right now. And Dr. Weissman, I'm really hoping that you'll help us with this as well. So I think what I'll do is present the case, just let you take a look at the 3 additional reports, and then ask Dr. Sela and Dr. Weissman sort of jointly to tell us a little bit about atelectasis. And in the case presentation, there's a place where we're supposed to put our questions. So I'll get to my questions in the case. So you can go ahead and put up the case, Mitra. And for those of you on the phone, like Kim Tiemann and others, I'll try to, so you're not missing any X-ray pictures, and I'll try to narrate this case so that you get, you can also have the details. So, and one thing I want to say that's interesting, Dr. Sela and Dr. Weissman, about all 4 of these cases, I believe they all come off ILO-B reader reports. So, and it's possible that they're all the same ILO-B reader. So that there could be an individual factor going on there. Great, Kim, I see your chat there. Thanks. So this first one, the index case here, was a 72-year-old retired coal miner. And if you scroll down a little bit to that history of present illness part, Mitra, thank you. And he came to the New River Breathing Center, Black Lung Clinic, as many working and retired miners do, to be tested to see whether they have black lung and to what degree, and also whether they are eligible for any benefits. And in this case, we're not talking about federal black lung benefits, which is one important category of compensation for exclusively coal workers' pneumoconiosis or black lung. In this case, we're talking about West Virginia occupational pneumoconiosis, which is what we talked about in our last echo, which is for any kind of dust exposure causing dust disease of the lung. So it could be, say, a sandblaster or a construction worker who's been cutting concrete on the roads for years, or even sometimes a truck driver, or somebody who worked in a mechanic shop and had a lot of brake work and had exposure to asbestos. So this is occupational pneumoconiosis. But the majority of people we see for this type of visit are coal miners. And a routine part of their exam is a special single view, anterior view of the chest that is called a B-reader chest X-ray that specifically looks for occupational pneumoconiosis. So he came with his wife from Webster Springs in Webster County with a history of mild increasing shortness of breath on exertion. He said this has been going on for probably more than 10 years. He had a dyspnea level of 2, which on a scale of 0 to 4 is, I can't walk up hills. I get short of breath if I walk fast, but not severe dyspnea, not dyspnea at rest, not requiring oxygen. He had only a very short smoking history and had quit more than 50 years ago. He had 36 years occupational dust exposure, all as an underground coal miner. He had previously applied for occupational pneumoconiosis benefits, but when he went to Charleston to go before the OP board, he was given no diagnosis and no percentage award. His primary care provider was in Webster Springs. He was not on any breathing meds and not on oxygen. His other comorbid conditions included type 2 diabetes, high blood pressure, hyperlipidemia, some coronary artery disease, and esophageal reflux. On physical exam, if you scroll down, he looked well, was walking independently, had no apparent acute chronic illnesses or weakness or shortness of breath on general appearance. Blood pressure 123/70, oxygen saturation 91% on room air, just a little bit low. His lungs were clear, and I would just say for a few of the people on this call who might not be familiar, even generally the examination of lungs on these minors is normal. Sometimes we do have some findings on examination and auscultation, but it's very common, even with people, for some people with advanced impairment, to have normal lung sounds as best we can tell. His heart rhythm was normal. He had no murmur gallops or rubs, but he did have a mid-sternal incision from previous coronary bypass surgery. He was wearing a splint on his right hand. His neurologic exam was unremarkable with normal speech and cognition and normal stance and gait. His chest x-ray showed simple pneumoconiosis with a perfusion of 1/1. And that perfusion of 1/1, good way to look at it is one of the ways that the B reader categorizes the chest x-ray on a standard worksheet that they have to fill out on every one of these x-rays that they read, is the profusion of small scarring, little nodules throughout the lungs. And there is there's a scale from 0 to 12. 1/1 is the 4th level on that scale. So on a scale of 0 to 12, he was at about a 4. His spirometry was normal, but his DLCO, which measures diffusion, was 50%, was 57% and predicted, which we consider to be a mild reduction. But with DLCO, any reduction is significant. And on the West Virginia compensation table of impairments, 57% diffusion level definitely is entitled to some compensation. So I described the chest x-ray briefly in the physical, but let's look at his x-ray report, please, Mitra. And I think it should be the first one I gave you. It would be one of the attached files.
Okay, let me go ahead and share one. So we have several with, I think they might be initials like GMLR. Do you know which one it would be out of those ones?
I think it's probably LR.
Okay.
We'll see if that, okay, well, this one isn't it, because this one has 1/, let's see.
I can pull up the other ones if you'd like.
But let's just take a look at this one. So here's one of, and I'll recognize his, I think, when I see it. Actually, this probably is his because, yeah, this is his. So as you see there, the narrative says simple pneumoconiosis 1/1, right peripheral pleural thickening. It's extremely common, at least by this reader, to see notations of pleural thickening much more frequently than we would see on regular x-rays done for normal clinical procedures. But here you can see it says atelectasis, right lower lung, showing increase from before. And if you look up at the top, it said he had a chest exam October 27th, 2016. So apparently atelectasis had been noted before, possibly by this same reader, probably by this same reader. And 5 years later, he gets another x-ray, and now this reader, who fortunately compares the x-ray to the previous one, says that the atelectasis is still there, same place, and increasing from before. And then the X-ray shows the wire sutures in the sternum, which are a mark that the person has had previous open heart surgery, which 95% of the time is coronary artery bypass surgery. So that's the X-ray report that goes with this minor. And this is the one that triggered me to submit this case. But let's look at the next three that then I noted and kind of decided to add to this collection. Morning, Grace Ann. Glad to see you with us today.
Glad
So,
to be here, Dan.
yeah. So Grace Ann, we're talking, Dr. Zulfikar wasn't able to be here today because of a canceled flight, and Mitra had asked us to fill in. So that's what we're doing. And our topic is atelectasis, which is a finding on chest X-ray. And Allison will be telling us in a minute exactly what that is. So the next X-ray, again, it's an OP X-ray. It says no evidence of pneumoconiosis. So this one showed none, but moderate elevation of right diaphragm and minimal plate-like atelectasis, right lower lung. Next one. And at the end of this X-ray series, Mitra, we're going to go back to the case report. Okay, here's another one. Now, interestingly, this one isn't an OP exam. This is a regular X-ray. So this one says atelectasis, left lower lung, elevated left hemidiaphragm, no congestive heart failure. So Allison is already observing that two of these X-rays have in common the elevated diaphragm, and she'll tell us about that too, I'm sure. And one more. And this is another X-ray done for occupational pneumoconiosis evaluation purposes. This one's on a minor with more than 40 years of coal mining, former smoker. He has a more advanced degree of pneumoconiosis on his X-ray. The profusion there is 1/2. And if I recall correctly, Dr. Weissman, I think I said that the original one, 1/1, was 4 on a scale of 12. I think it's actually 5 on a scale of 12. And this one is 6 on a scale of 12. So a little bit more X-ray marking of pneumoconiosis in the lungs. But down at the bottom, you can see it says plate-like atelectasis at lung bases bilaterally. So that's our series of 4, Dr. Sela and Weissman, and I don't see Dr. Wernz here yet. I had asked him to also chime in. So then my questions for this case, which they used to be when we submit the case on the case submission form, the questions are at the bottom, but the way West Virginia Echo has this set up now, they've got them at the top, which is probably good. So my question is, what are the etiologies, that is causes, of an X-ray finding of atelectasis? And really, what does it mean? What's the how bad a thing is atelectasis? And is it a reason to be especially concerned? In other words, so what's the prognosis if you have atelectasis? So what does it mean? What are the causes? What's the prognosis? And with that, I'd like to turn it over to our other hub expert pulmonologists here, Drs. Sela and Weissman. And if Dr. Wernz or anybody else comes along, we'd help us out. Now, when I talked to Dr. Sela about this on Friday, she mentioned that this finding often causes concern on the part of primary care physicians or PCPs, and I guess I fall in that category. So, Allison, go ahead.
Can you all hear me?
Yes.
Yes.
Okay,
Loud and
all right.
loud and clear.
Okay. So atelectasis is a collapse of part of the lung for some reason. That area of the lung is not getting enough oxygen, or is not getting enough air, enough oxygen to stay inflated. And so it appears on the X-ray as a shadow of some type. And so there's multiple different reasons that that can happen. Usually there's something pressing on the lung in that area, whether it's fluid from a pleural effusion, whether it's diseased lung from pneumonia or a cancer or a large nodule. It can also happen, we see it oftentimes in like post-op patients that are not taking nice deep breaths and they've been in bed for a couple of days. And so, they're not aerating that specific area of the lung. And it can cause shortness of breath. It can cause, if it's severe enough, it can cause you to have low oxygen saturations. And, the easiest way to treat that, or the best way to treat that, is to treat the underlying cause. Much like many other things that we do in medicine, you treat whatever's causing it. So if it's related to pneumonia, you want to put the patient on antibiotics. If it's related to a large pleural effusion, you want to drain the fluid. If it's related to the patient being in bed and just not taking nice deep breaths, you make sure that they're on incentive spirometer. You make sure that they're up and moving. You want to make sure that their pain is controlled, so that they can take those nice deep breaths without having any issues, or trying to hold back on their breaths. And so again, like many things that we do in medicine, you want to treat the underlying cause. Some patients have something called rounded atelectasis. And basically what rounded atelectasis is that an area of the lung has sort of folded in on itself. And so what you're seeing is sort of double lung in that area. And that causes the lung to look a little bit thicker. Excuse me for one moment. Bye, sweetheart. Have a good day. Sorry. She's almost 2, and if you don't say bye to her, she'll keep going. This rounded atelectasis is something that patients will often be presented to us because they've got this round mass in their lung, and what is it? And we end up following them, for a period of 2 years to look at this area, and it doesn't change and it doesn't grow. And then we usually are able to determine that this is an area of rounded atelectasis that the patient will likely have, forever. So that's sort of my 2 cents. I'm happy to answer any more specific questions, but I'll see if Dr. Weissman has anything else to add.
Not much to add, except that it is frequently an incidental finding. When you see it, you need to make sure, like Allison was saying, that there's not a treatable underlying cause, airways being clogged up by infection or a nodule, with poor aeration, or you could have problems where for some reason people aren't taking deep enough breaths, and so massive obesity, we often see little lines of atelectasis at the base. If there's diaphragmatic weakness, your first patient had a cabbage, and had a high riding diaphragm, so you wonder a little bit about that maybe, but I think when you see that, you need to look for some underlying cause that would either cause the lung not to be aerated or to, cause some sort of external pressure at that point. And if you rule that out, and again, in your first case where it had been stable for many years, it's probably less likely that there's something bad underlying it. So I'll stop there.
Well, thank you all so much for this case presentation. We really appreciate it, just because we had a didactic and you guys came through really last minute. So we truly appreciate it. Did anyone have any questions or comments about this case that was just presented?
Mitra, well, we're waiting for people to come up with some questions, which I'm trusting they will. I would like to ask, I'm excited to see that several more people have joined us, and could we maybe give them a chance to introduce themselves?
Absolutely. I think that's a great idea. Let's see. So I think Grace Ann Dorney, you had logged on a little after as well. Did you want to do a little introduction?
Sure, I am still Grace Ann Dorney Koppel. I'm still president of the Dorney Koppel Foundation, and I'm still very, very anxious that all of you will support copdsos.org because it's an opportunity, we hope, to find the missing millions. And also, there is we can sign on to try to get more funding for COPD. So if you have not gone to copdsos.org, I encourage you to do so. We also are very fortunate because we have found 2 influencers for social media who will, without being paid, support us. One is Lyle Lovett, who is a country music star, and the other is Dr. Sanjay Gupta, who has the most following of anyone who is in public health. So we're hoping that this social media aspect of the PSA campaign will catch on fire, and I need all your help to do that.
Thank you so much, Grace Ann. How exciting is that? That's awesome. I'm so happy that you're getting some great supporters. And if you want to send me any information about that website and everything like that, just let me know and we can add it in the recap email as well. Thank you so much, Grace Ann.
We could even add it to social media too. Just send it to me and I can put it on Twitter and Facebook as well.
Absolutely. That's a great idea, Elizabeth. Thank you. Let's see. And Joseph? Joseph, we're just doing some brief intros for those of you who hopped on a little bit after we got started. You can also chat in as well. Oh, no mic today, no worries. Thank you. And we have a username S Morgan. And you are still muted. The unmute button is on the bottom left hand side of your screen. All right, no worries. And Lisa Emery.
Hi guys, can you hear me?
Yes, we can hear you.
I'm Lisa Emery. I'm a respiratory therapist at New River Health Association and a Grace Ann Dorney Pulmonary Rehab Program. I'm the program director, and it's great to be here this Monday morning, and my kids are on the bus and off to school.
Oh, that's awesome. It's great to have you as always, Lisa. Thank you.
Thank you.
Let's see, and Johnny. Johnny Mullins chatted in, SWVHS, respiratory therapist at JDPR. Everyone have a wonderful week and please be safe. Thank you so much, Johnny. And Tim Ritz. Tim, I do see you're unmuted, but we're unable to hear you. You can also try to chat in as well. Thank you. And we have a number ending in 22731 or 2731, I should say. And to unmute, you can do the *6.
Hello.
Hi, yes,
This
we
is
can
Tim
hear
at
you.
Jackson General. Hi, everybody.
Oh, thank you. Thank you so much. Alrighty, Dr. Doyle, I think that was everyone who had logged on a little after. If we missed anyone with intros, just please feel free to chime in and unmute.
So that's great. And I want to say that I'm pretty excited by the turnout today because this is our best turnout from Grace Ann Dorney pulmonary rehab sites, I would say in a couple years, or at least in a year. And that's partly because Tim Ritz from Jackson General is with us. It's really great to have you, Tim. Johnny Mullins is with us representing Southern West Virginia Health Systems. And so we've really got everybody except Boone Roan, and actually, and Tim, if you would confirm whether this is still true or not, but Angel Anderson, who was with Jackson General, I think is now the director at Roan of their program, of their pulmonary and probably cardiac rehab program. Is that still true? Lisa or Tim, either one of you might know about that. I see Tim trying to connect. So you can jump in whenever you kind of get connected. So that's really exciting. And then Grace Ann, if you can, what I would like to do is go ahead and share screen and let you give people a little tour of the COPD SOS website right now. And if you can get it up, fine, go ahead. If you can't, I can share the screen and you can talk us through it. You want to do it or you want me to do it? And then Mitra, you have to let us share.
Yes, let me give you that capability, Dr. Doyle. You should be able to screen share now.
Okay.
This is Alice. This is Allison. I just wanted to mention, Grace Ann, I had two of my patients, the sisters that are in the video, in my clinic last week, and showed them the video, and they were just so touched and so moved by what they saw. So hopefully this has the same impact on COPD patients and those people that are going to hopefully give us money across the country. It's a very well done site.
Okay, and I think I can share it. I'm trying to see here. Here we go. People see it?
Yes, we sure can.
Okay. So Grace Ann, if you're there, you wanna, I'm gonna just jump in anytime. So here's the site. COPD SOS, we're sounding the alarm for COPD, and you can get to this just by typing in your browser COPD SOS, and that'll get you to it. There's a link for that the COPD Foundation has it, but this has its own independent link. I'm not going to try it. It sounds like there's a video here, Allison.
Yes,
Okay.
with patient testimony.
Okay. Here's Dr. Fauci, and it looks like there's a video of him speaking. Facts and figures about it. As Grace Ann said, the missing millions. And then here's a video by Bo, former carpenter who was at Ground Zero. And then are these your two patients right here, Allison?
I can't.
Oh, you can't see it,
but probably.
Okay, they on the website they're referred to as Terry and Sandy.
Oh yes, yeah.
So there's a number of testimonies. And so, Grace Ann, jump in or anybody, interrupt me anytime, because the purpose is to give people direct exposure to this now. But the whole issue of early detection of COPD, so we can do early treatment and intervention, including pulmonary rehab, including smoking cessation, including education, including immunization, et cetera, is really important. And we all know that there are, like, for example, I was doing pulmonary rehab recruitment outreach this week, and I called a patient who was on our list and was telling her about pulmonary rehab. And she said, oh, I think my sister might be interested in that. And actually, I think my sister-in-law might be interested in that. And one, her sister had not been diagnosed, and her sister-in-law wasn't even going to the doctor at all. But we all walk through the grocery store, walk through the big stores, and we go through the cash registers, and we just look at people, and we just know that person probably has COPD. We can tell, blah blah blah. So I'm gonna get out of this share unless anybody wants to comment on it before I do. Okay, but it's there and it's easy to get to. Okay, so any questions about atelectasis? Anything anybody wanted to ask, or any things that you've run into with it? There's a couple questions in the chat waiting, but before we go to those, I want to make sure to give anybody else a chance to comment. And by the way, it's really great to have Sheila Morgan, who's with the Black Lung Clinic there at Mann, with Johnny Mullins. And Sheila, we were mainly talking about OP X-rays and OP minors who came in for OP exams today. I'm just curious, when you do these X-rays there, do you notice that you see people on the B reader X-rays with the finding of atelectasis? You're muted.
You're still muted, yep. The button to unmute should be on the bottom left.
While we're waiting for her to jump in, Allison, I want to warn you, before we get off, I want to do a little role play. And the role play is going to be, I'm the patient, and I'm asking you what my X-ray showed, and you're telling me that it showed this atelectasis, and I'm going to be asking you what it means. And so it's kind of giving you an opportunity to model for us how you explain this to a patient, because I've found it kind of difficult, to tell you the truth, as you and I had discussed. Okay, so Sheila, if you get to jump in, go ahead. Okay, so here's I have two questions actually, and these go to both Dr. Weissman and Allison. You know, you basically, what you said was you try to find the underlying condition and treat it. In two of these cases, I guess you could say the underlying condition was the elevated hemidiaphragm. Well, one of them had diaphragms on both sides elevated and atelectasis on both sides. Not sure what that means unless poor inspiration, but two of the cases really didn't have anything except that previous history of coronary artery bypass surgery. And David, you used the term incidental finding. So I guess my question is, what about when there just doesn't seem to be anything, and these guys or this person doesn't have any apparent reason? And in a way, this anticipates our little role play, Allison. You know, how much can we reassure them and ourselves that this has a benign prognosis, and we just have to keep it under observation, I guess. And a corollary question would be, is this a reason to order a chest CT or not? Go ahead. Allison, you're muted. David, you're muted. There you go.
I think a lot of it depends on the clinical context, right? I mean, is the person coughing up blood? Are they losing weight? Do they have a cigarette smoking history? Are there other things that from the clinical history? I mean, what you provided us were very short little overviews of these patients. But you take a history, you do a physical, you look at the context, and then you decide if further workup is needed. I have a low threshold for getting CTs on people, honestly, but there needs to be some clinical basis for it. But basically, you want to rule out something that's either blocking the airway or something that's causing insufficient expansion of the lung, because those are the things that are going to cause lack of aeration in alveoli and collapse. So I hope that's helpful.
I would agree with what Dr. Weissman said. My threshold is also pretty low for getting CTs, as long as there's an indication.
Is this an indication?
I would say it is,
Okay.
just to make sure that there's no, intrabronchial lesion or something like that that could be contributing to the atelectasis. Now, if these patients had bypass surgery and when they were discharged from the hospital, they had atelectasis in the same place, probably not. But if this is a new finding or something that wasn't there previously, then yes.
And is an LDCT good enough? Because many of them have that risk factor and have never had an LDCT and are eligible. So I guess I answered my own question. If they've never had an LDCT and they're eligible, do it. But is it good enough as the CT workup in this situation?
I think definitely.
Go on, I'm sorry.
No, I was going to say, at least for the initial, and if there's something there that needs further looked at, if this does turn out to be a mass and you need to look closer at the lymph nodes, then obviously you could get a CT with contrast down the road, or a PET scan or something else. But I think initially, at least, it'll rule out anything major.
David?
Yeah, and I totally agree with that. And I guess I'll slip in, that from the standpoint of low dose CT screening for lung cancer, there's really very low uptake of that among people who are eligible for that, and so age 50 to 80, more than 20 pack year, a history of smoking, a quit less than 15 years ago, or still currently, smoking. Folks in that with those criteria are eligible for a low dose lung cancer screening with an annual low dose CT. And it's really underutilized. And
Luann, if you're with us, I think it'd be worth a minute to remain on this tangent, this important tangent for a minute, because what's your comment on what Dr. Weissman just said and how you've worked on it?
As far as the insurances right now, we're having a little bit of trouble with our local, I want to say even trouble. They're a little hesitant to allow the new suggested guidelines for age 50 to 80. So any of our Medicare patients, they're still using the 55 to 77 with 30 plus pack years. But any of the other carriers, they're allowing to use with the new ones. And as far as the eligibility, definitely, if anybody qualifies in those, please send them for that, because they're finding that they need to catch it sooner. And especially this past year, we've noticed, because a lot of people did not go due to COVID for testing and wouldn't come in for their follow-ups, the lung RAD4s have increased. So it'd be definitely to their benefit if you can catch them, please have them go, or at least recommend it.
Luann, what do you think has been the impact of your team on getting LDCT to qualifying patients there at Dawes at Cabin Creek?
Impact in that our providers, before we started really working with the American Cancer Society on our project about 5 years ago, they were occasionally sending patients. They were aware of it, but it has been a huge step forward, because we kind of our department works as the liaison between hospitals and all the sites. And so every month we look at the ones that have been sourced, and then try to make sure that any of the lung RAD4s especially are followed up with. So, and then we have Dr. Ely's group working with us to source to them specifically for the lung RAD4 follow-up. So I think the providers feel very safe knowing that there's a constant follow-up with that. So no matter what, that there's somebody tracking it and making sure. So they've really, this last month, it was a huge amount of patients compared to even a previous COVID that were sent for their low-dose CTs. So I think they're really keeping tabs with that, making sure that if it's possible that they're sending them.
Thanks for slipping that in, David. Important topic, maybe one for an echo sometime. Okay, Dr. Sela, you ready?
I'm ready.
Hi, Dr. Sela. The Black Lung Clinic at Preston Taylor sent me over to see you because they're concerned about this X-ray report. They said they were going to send it to you. Did you get it from them?
I did, yes.
They said something about me having a collapsed lung, and that sounds pretty scary. So what do I need to do about that, and what is it?
So the X-ray report, when you read it, will say atelectasis. And that's what they're talking about when they talk about collapse of the lung. And usually what this is it's an area of the lung that's not getting enough air for a specific reason. There's lots of different things that can cause this. Usually if there's fluid pushing against the lung or something else pushing against the lung, if you're not taking a deep enough breath, there's all sorts of reasons why you could have atelectasis. So one of the things that we need to do is we need to look a little bit closer and make sure that there's none of those scary reasons that are causing this atelectasis. So what I would recommend is that we get a CT scan just to look and make sure that we're ruling out anything that could be serious with this. Lots of people have atelectasis and they live their lives without even knowing it. This can be something that we call an incidental finding. So they weren't necessarily looking for this area of atelectasis. They just noted it because you had the chest X-ray done. And so there are lots of people that walk around that have never had a chest X-ray and don't even know that they have it. So for most cases, it's not anything serious, but we do want to rule out those things that could be serious.
Okay. I had a cousin who was in a motorcycle wreck and he had a collapsed lung and they had to put a chest tube in on him. Could that happen to me?
In this instance, looking at your chest X-ray, probably not. That is usually something that happens when there's some sort of trauma or accident. And that was not the case in your situation. And so most likely you will not need a chest tube in order to reinflate your lung. Usually what we do is when we find out what the cause is, then we'll treat that cause. So if there's fluid that's pushing against the lung, we'll drain that fluid. If there is a mass, we'll need to look a little bit further and see what the cause of this mass is and if it's something that we can correct in order to re-expand the lung. Sometimes it happens in patients that just have not been taking nice deep breaths, and if we get you to work on taking those deep breaths using the bottom parts of your lungs, sometimes that will help to reinflate the lung. And then there are certain people that it will never reinflate, and they just live with that without any problems.
So I should be taking more deep breaths?
Well, that's one of the things that you can do. We can give you an incentive spirometer to use while we're waiting to get our CT scan. And if that is the cause and it fixes itself before the CT scan, we'll definitely be able to see that on the CT scan. Well,
thank you. That helps me know what I need to do next. So do I need to, so you're going to order the CT scan and then I'll come back and see you again?
Yes. Yep, we'll get that ordered and put through the insurance. And once we get insurance approval, we'll get that scheduled and then we'll get you back in here to discuss the results.
Okay, it's nice meeting you, Dr. Sela. Thank you very much.
You're welcome.
Well, I'd go on another half hour with that, but and ask a bunch of other people. But I'm handing it back to you, Mitra and Elizabeth. Thanks.
Thank you all so much. That was a really good mock patient scenario, a role play, I should say. It's really good. Thank you. I think we need to have more of those moving forward. Did anyone have any questions, comments, thoughts that they wanted to share with the group? Luann, I saw you chatted that in, clarifying for the LDCT for Medicare patients. Thank you so much. She just mentioned due to the issues with Medicare giving pushback to authorize the new guidelines, the local hospitals have decided to wait until Medicare is more on board with approval for services. Thank you for sharing that, Luann. Yeah, we have about 7 more minutes. I didn't want to end the session short, but if anyone had any other comments or thoughts, please do chat in or unmute. Alrighty, well, big shout out to Dr. Doyle, Dr. Sela, and Weissman for all 3 of you for coming through and presenting this case today and just having such a great session. So we really appreciate that last minute pull through. But the only announcement that I have is that our next session will be on actually September 20th. I know that sounds a long time from now because September 6th is Labor Day, so we won't be meeting on September 6th. So on September 20th, Dr. Sela will be discussing pulmonary rehab update. So keep an eye out for that reminder, and we'll see you all next time. Thank you all so much. Bye-bye.